maybe go straight to slide 2. Thank you, Adiba. So if we go on to the next slide, that's brilliant. So we're going to talk about the study we've been doing, and from that, what sort of things we're recommending or hoping will make a difference to how we deliver autism service, particularly around diagnosis, which was our particular focus. We started the study with a sort of overarching question of which autism pathways provide timely and high quality diagnostic services, for whom, in what circumstances, and at what cost. This was done as a realist evaluation, so the sort of language like for whom and what circumstances is sort of very realist thinking. Moving on to the next slide. Underpinning this, we had a number of aims. Firstly, to examine existing models of autism service delivery to see what lessons we could learn from teams that had already achieved sort of good outcomes in terms of their sort of quality and timeliness, and what things underpinned that success. We hoped through this, which is the stage we're now at, to inform commissioning around how we could deliver high quality diagnostic services, but alongside this offer positive experience both for the children and families going through the process, and deliver individualized, needs-based and holistic packages of care. As I said, we adopted a realist methodology, and that's included literature review, a survey of current practice from 128 centres in the UK, an in-depth analysis looking at 6 sites in a lot more detail, including interviewing parents and young people and clinicians working in the services, and an economic evaluation around those teams. Moving on to the next slide. Very quickly to explain a bit about realist evaluation. It's a method that's been adopted over the last 20 years or so to look at particularly things like complex service delivery, and usually in a situation where traditional medical research would be asking, does this treatment work better than another? This is more recognizing that most approaches, say, to service delivery might work well for one particular patient group and maybe less well for someone else, and are also affected by what's going on around you, which we'll show in a minute. So it's asking questions about what are the contexts that affect service delivery, what are the mechanisms that at play that then lead to either positive or negative outcomes. Moving on to the next slide. So, for example, if you were to look at the contexts that might impact on service delivery around the setting that you're in, are you an urban or rural area, which might make it easier, say, to access some services? If you're looking at, say, joining CAMS and child development teams together to deliver an integrated approach, are you co-located or not? Are those services in single or multiple provider trusts? And again, if they are in the multiple trusts, do you have different priorities? So a CAMS team might well be focused on adolescent mental health, whereas a paediatric and child development team, my interests will lie in areas like early neurodisability or children who are in the care system. And underlying that, one of the big elephants in the room, have we got the funding to deliver a decent service? Next slide. One of the questions we've been able to address or start to answer through the study was, why have we got long waiting lists? So the study was initially funded by NHS England when they produced the long-term plan, and part of their goal was to address those long waiting lists. Moving on. With the survey, we identified a number of challenges for teams around the long and growing waiting lists. One of the key ones, which I think needs addressing in terms of resourcing, is that the number of referrals we're receiving have doubled just between 2015 and 19, and then from consensus events we've held more recently, it's evident that most teams have seen ongoing increase since then, which is evident if you look at the chart I've put up, or the graph on the right, which just reflects my own local data in Mid Sussex. The blue line is the number of children we've managed to see each year, and actually we've been quite impressive in how well we've increased our capacity. Unfortunately, the green line shows the number of referrals we're getting, which have gone up quicker. And the yellow line shows the number of children sitting on our waiting list, which again, as the gap between demand and capacity has increased, so has our number of children waiting for their assessment. And that's been reflected certainly our local, if you go back to 2015, we had a maximum 6-month wait between our initial assessment and diagnosis. We're now looking at 18 months to 2 years. Other issues have included the feeling that the case complexity has increased, that teams are not, or only a third of teams had any increased funding, and that was often in the form of time-limited waiting list initiative, which doesn't really help that much in the long term. Teams are struggling to recruit and retain staff, and there is an insufficient number of people with trained in the relevant professions in the country to fill the number of posts we ideally would like to have. 50% of teams as a result also report long-term vacancies. The quotes just reflect some of what people were telling us. As an example, one of the service leads commented that their service was commissioned to see 60 children a year, but the numbers have now trebled. And they said we see 2 children a week, but we get 8 referrals, and that is very typical of what's happening nationally. Moving on to the next slide. We know that diagnosis is complex. Autism is a condition that takes a lot of teasing out, and it can look different in different children. There's no blood test or x-ray to make my life as a diagnostician easy. And as a result, it takes, in our own research, about 13 hours of professional time, costing about £800 to £900 a child. As I said to the previous group, actually, if you compare that to the cost, say, of delivering special needs, even for a child who's at the sort of lower level of special needs in a mainstream school for a year, is about £6,000. If you look at the cost of a child on ITU overnight, is not dissimilar cost. Moving on to the next slide. We've also identified what one of the commissioners called siloed working. So where you've got CAMS teams or child development teams working in isolation, and only 10 of the teams were integrated out of the 128, there tend to be gaps in your skill sets and service delivery. So CAMS teams were unlikely to examine the child or consider things like investigation for underlying genetic disorders, whilst as a paediatric team we had difficulties accessing, say, psychology if we wanted to look at more complex children with concerns around their mental health or things like attachment disorder. Moving on to the next slide. In terms of costing, we also looked at the 6 teams in a bit more depth. But what's interesting, particularly if you look on the left, which are the 2 CAMS teams, the sort of blue graph represents a team that effectively operated a more holistic neurodevelopmental type pathway, where the children were undergoing a broader mental health assessment and support, and the autism assessment was done within that framework. The red one represents a team that operated a autism single condition diagnostic pathway, which looks a lot cheaper, but obviously doesn't answer such a broad question. So I guess you pays your money, takes your choice. And we'll talk a lot more about neurodevelopmental pathways later on. Moving on. Thinking about solutions, and we'll go on to the next slide. We come up with some broad recommendations, which we'll cover shortly. Some of the things that we will talk about around the need to be flexible in our approach, to recognise that some children are much more straightforward diagnostically than others, yet at the moment pathways often will put the same effort into each of those children. We're going to talk about neurodevelopmental pathways as something that as a team we strongly believe is a big part of our future way ahead, but needs to be done carefully so that we don't end up with teams stretched beyond their current capacity. We're also going to talk about the benefits of what we're variously called streamlining or tailored pathways or abbreviated pathways that recognise some children need more assess or more straightforward to diagnose than others. Often, ironically, those who are the most straightforward diagnostically are often the ones who need the most support and are likely to be what some people now call profoundly autistic children. Going to talk about skill mix. Who can be part of your team? Do we stick with that traditional paediatrician, psychologist, and speech therapist? Or what about bringing in things like educational professionals who may bring a really useful skill set into the assessment? I think one of our other key areas that we've identified over the study is also the need to focus more on the strengths and needs of the child and not just on their diagnosis. Although we're not at the stage of saying we should replace diagnosis completely, as we still think that's an important part of the child's journey and family's journey. But also in relation to that, it's really important that support is available, not just post-diagnosis, but should be there from the start of the process, and not just for those who get a diagnosis. Over to Will, and changing on to the next, actually, no, I'll do the next slide and then hand over to Will. Just to give a background of what good practice looks like, we went back to the NICE guideline and have paraphrased this in realist language. What should we be doing? Not the common experience of parents that they go through a process that asks the question, has the child got autism, and then stops. We've jumped back slides, hang on. But the guideline talks about delivering a multidisciplinary assessment that is able to assess the child's strengths and needs, to recognise, actually I'll read it properly, if there's a multidisciplinary assessment by a team with competencies in child neurodevelopment and mental health, then autism will be recognised as a complex condition that relies on detailed history and observation across settings, leading to an accurate diagnosis, recognition of associated comorbidity such as ADHD and intellectual disability, and the ruling out of complex differential diagnosis. This should also create an accurate picture of the child's strengths and needs that can inform individualised packages of support and intervention. And importantly, as we think about what does integration look like, not just as a health issue, but this should be delivered across health, education and social care. And we should really add the voluntary sector as well, as they often play a key part. Over to Will, and the next slide, please.
Yeah. Okay. I can't see that very large now, Divas, but I'll do my best because I'm seeing it on normal PowerPoint, but I don't want to muck up other people's views if we now change it. Okay, so I'll do my best to talk through the 7 themes that we found on the REAST project, which are a whole host of recommendations which we would suggest to pathways and commissioners to think about in terms of what you do next. We always thought about this within the project as being kind of like a shopping list that we were going to give to NHS England at the end of it. And depending on what you decided you could do within the resources that you have, obviously with the elephant in the room being that, you know, financial resources are the ones that are most needed, will depend on what you can do. But of course, one thing that came out of all our analysis was you basically pay your money and you take your choice. But clearly more investment was needed to all those teams to get diagnostic pathways up to a better standard. In terms of recognition, system-wide awareness seems to be coming out more broadly across the country as being a national challenge. Worth saying also that all of these 7 things I'm going to talk about were across 1,500 pages of interviews that we did with a vast number of different kinds of professionals and families and focus groups and children to whittle down eventually what were some early themes that came out from the literature to these recommendations, all 27 of them. We reckon that ASD autism recognition needs to be widely targeted towards generic staff that don't necessarily have that specific understanding that some of us may have here. Specialists and health visitors is something that should be thought about. That comes up a lot in terms of conversations, in terms of what would be a good link person for families and for children. And training on meeting the needs of the family needs to be definitely much more specifically focused in on. NHS providers need to be thinking therefore about designated link roles to schools. And we even revisited the whole idea of remember the days of school nurses and when there were more ed psychs around. And so we need to develop and liaise on interventions and referrals. Next slide, please. In terms of referrals, local services need to make sure that those systems that are in place help inform decision making over what the child needs so that they are timely and to task, and so that the process is actually up to date. So children, if they come into a system and it takes a long time to be seen, or say they've crossed over into a transition between primary and secondary school, or leaving secondary school, that things are left up to date, and so that children are actually described effectively, because often it can take so long. The initial description is no longer describing the child in front of the individual. So tools need to be made better to enable things to be kept up to date, and information needs to be gathered that is sufficient to help parents along the pathway, and to make the clinicians have a better and easier referral. Next slide. In terms of service organisation, I think I hinted at this already. One thing that came up from all of our work was that often children can go into another service, whether it's to an ADHD service, one of these silos Ian was talking about, and we need to ensure that once a child enters the service as a one-stop shop, they enter it once and that's it. They don't get restarted again. They don't get sent somewhere else and they go back to the beginning of the queue again with a different start date. Once you're in, you're in. And it may to make sure that that data is carried over, and that coexisting conditions diagnosed alongside others, so that there's more of a neurodevelopmental broad view, and so that clinicians get freed up to be able to say, yes, this child has autism, but they also have ADHD as well, rather than it going off to a differing team. That kind of service provision needs to be clearly explained to parents so they understand what to expect. And if it becomes multifaceted, so for example, as happened during the pandemic, with more online tools, the parents are aware of that, and that it's not a surprise to them as to what the pathway is going to look like. So it's on public-facing websites as to what that one-stop shop will look like, and that there's continuity in terms of a health professional that is a key point of contact. So it's the same person throughout the whole process, and so they can approach that person for help as and when they need it. Next slide. In terms of skill mix, one thing that's needed is that it needs to be based on the skills of the individual, not necessarily the role that are in, whether it's the grade or whether they happen to be, like a deputy head in a school. It's much more based on how much experience they have. We know from our experience that other countries, give an example here, Australia, we haven't adopted it here. They already say that you need to have 2 years of experience of working with children with autism before you'd even be considered for a role within a diagnostic pathway, which I think is very good. There's like, a certain baseline of understanding. Those skills need to be matched to the local demographic, and they're underpinned by teams working together, so that none of this, like what we heard is called loops, hoops, and silos gets removed, so that teams actually talk to one another. This came up in our last workshop, but talking about integration, making sure that education is part of that, so no integration without education should be important. And this also for healthcare services means that retention and co-location of teams works really well, whereby those teams are actually, housed within the same building, and they actually talk. If a child is going in secondary school and they've now got much more mental health needs, that they're able to talk to paediatric teams and share that information very clearly. Any health professional that is part of the assessment should really be part of the formulation at the end of it, so that certain members of teams don't trump other members of teams, because it may well be that key point of contact was key right the way throughout the support, but then they tend to get opted out in sort of final formulation. Next slide. Is this the one on, I think this might be assessment, the next one. Yes, so this is the most lengthy one. So there's conversations about making sure that within pathways there's flexibility, so that the assessments can be possibly abbreviated where necessary. And when this occurs, children should be discharged without a full assessment of their needs being taken into consideration, so that anything that's coming into schools after children have been assessed is based on strengths and needs, and information that's being received is actually of value. For example, if there are issues clearly with the child's short-term, long-term memory, working memory, central coherence, what does that mean in terms of schools? How could you actually help a school actually address that in a classroom? That's the kind of things that schools are kind of interested in getting. In terms of assessment, digital technology should be used judiciously, so not all the time, and so parents should be given a certain element of choice within that, and make sure that any adaptations that are made are clearly explained and made as inclusive as possible. And any support, we were initially pulled up on this when we did our first draft of our report that went to NHS England. We didn't mention the word support enough. Support is clearly in there in terms of something that carries on in parallel to the diagnostic process and almost independent of it. So it shouldn't depend on you getting to the end of the pathway or you doing an early bird program before you get access to it. It should just be there in terms of a trans diagnostic view, that you speak to the parents initially and say, well, what do you need? What's actually the problems that you have right now? Is it with sleep? Is it with behaviour that challenges? What is it that you need assistance with? And obviously those children that want to be involved in the pathway should be allowed to be part of the pathway, and at any point parents are allowed to have translations of those documents and enabled to be talked through what is actually happening to their child. Next slide. In terms of feedback, practitioners need to make sure they maximise opportunities to talk. Parents need to be given the opportunity to follow up with somebody known to the family. So as we were saying earlier, where it's a specific individual that is known to the family that follows them through the pathway. And if the child wants that feedback, it should be made accessible to them always. We know from research evidence that the sooner children know what their label is and the earlier they know what their label is, the better the outcomes are for them. And reports surely need to be shared as soon as possible. If it's within 4 weeks of the assessment, that's best practice. It could literally just be like a page of a summary report if it was needed, say, for a job or for transition to secondary school or even to A-level college. That could be useful. And with parental support, these reports need to be shared freely amongst the key stakeholders, that is like schools and health, with nothing redacted. Next slide. Training needs to be local, regional, and we need to have some much more agreed understanding of what we mean by autism nationally. For those members of staff that want to join diagnostic teams, we need to make sure that succession planning is actually useful and valuable, and people want to come and work within these teams. We know that psychologists often find that being almost stereotypes and going into a role where they're just doing diagnostic pathways and diagnostic interviews can tend to kind of limit their role and put people off in terms of wanting to do that as a role. Natural wastage where members of staff end up retiring. We need to make sure, as we've seen, I'm sure in the news, that those members of staff that are going are replaced and are properly trained for. And so core MDT disciplines, multidisciplinary teams are keep at their stable rate they are now, and an increased pool of specially trained practitioners is accounted for locally. Next slide. Okay, Ian.
I should just say we've got at the end, we're going to free up some time for questions. If you have any questions that you're already thinking of, by all means, put them in the chat, and Will's going to keep an eye on those whilst I finish the last few slides. So the first thing we've said about neurodevelopmental pathways a few times, and I think one of our key recommendations is that, although not to rush into it, that from the point of view of the family journey, going on a pathway that addresses the child's broader needs rather than purely focusing on autism gives them a much better journey. I think what part of the problem we've had is that if you go back to the NICE guidelines, we have separate guidelines for autism and ADHD. And equally well, if you go back to the previous diagnostic criteria like DSM-4 or ICD-10, in theory, you were not allowed to have a diagnosis of autism and ADHD. You could have one or the other. Yeah, we know from research and clinical practice, in reality, autism very rarely comes on its own. It's almost very frequently associated with a number of different neurodevelopmental conditions like ADHD and language disorder, developmental coordination disorder, and that children with autism are very likely to develop secondary mental health conditions, or indeed a number of adolescents who present with a mental health conditions such as an eating disorder, often when you assess them properly, have an previously unrecognised autistic picture. This is recognised in the concept of essence, which was developed by Chris Gilberg. And he said, where if you start, say, with a diagnosis of autism, you should really be keeping an eye on that child over time. They're likely to develop or have other recognised conditions, both neurodevelopmentally and in their mental health as they get older. Next slide, please. We also, as the slide comes up, have done a study looking at the efficiency of different approaches. So on the right, the diagram on the right, and we've listed the paper that you can find this in, looks at a journey of a child where you have separate autism and ADHD pathways. It could be autism and learning disability or any other of the different conditions. So where I work in West Sussex, we have an autism pathway in the child development team. We have an ADHD pathway in CAMS. And often the journey starts with referral bouncing backwards and forwards, usually ending up with us because we're nice. But each team will say, well, there's more of an ADHD, so start with ADHD, there's more autism, start with the autism. But for the child and family, they're ending up going through two parallel pathways where they're both, and on both pathways, there's a lot of repetition of things like school observation, history taking, and so on. If you look at the neurodevelopmental pathway as it operates in Peterborough, that child goes through a single pathway that addresses both questions alongside each other, and is much more efficient. It costs less, at least in terms of the whole system, and gives a much better journey for the parents. The challenge is, if you ask my team that currently is funded and commissioned to operate an autism pathway, asked us to do the ADHD as well without giving us additional resource, it is more costly to assess a child for autism and ADHD than just to look at autism. But in terms of the individual pathway, actually for the health economy, for those of you who are commissioning, it's much more efficient, and therefore overall you will save money by operating that single pathway approach. But you need to recognise the team delivering that will need additional resource to do so. Next slide, please. We put these up, just some questions you might, if you're looking at neurodevelopmental pathways, just to consider. So as teams are currently commissioned, do they have the competencies to deliver that? So have you got skills in your team to look at autism, ADHD, learning disability, and so on? You need to think, what would the impact be? As I've said, if you just rush into this and expect a team to suddenly move from just looking at autism to looking at autism and ADHD without giving extra resourcing, the likelihood is teams will end up collapsing. Moving on to the next slide, and I guess we need to think about, how does integration work out? What does that look like? And obviously the ICSs have a key role to play in that. We've talked a bit about tailored assessment, but the idea that some children have very, very obvious signs of autism. Why are we putting them through the same very detailed assessment that we're giving to a child where the diagnosis is far less straightforward? And there are a number of places already moving in that direction. Looking at the next slide, please. And we'll go on to the next one. Again, the slides will be available, so by all means have a look at those questions in a bit more detail, as if you're working with as a commissioning group or as providers as well. Moving on to the next slide. We've also talked about skill mix, and I think there's a different parts of this. Having the core team with the range of competencies you need to look at either autism or the broader neurodevelopmental picture, but there's also an element of skill mix of saying there aren't enough doctors and psychologists and speech therapists. Are there other people that could get involved in a diagnostic role? Some of those might be things like nurse specialists, early years practitioners, but also recognising that people who come from educational backgrounds, things like teachers and educational psychologists, also may have a very relevant competency to offer to that process. Excuse me, next slide, please. We talked about the absolute importance of firstly recognising a child's needs as well as the diagnosis, but from that of supporting the child, but not waiting for the diagnosis. And equally well, support should not be diagnosis dependent. We often get the challenges where you don't give an autism diagnosis at the end of the process, that parents then feel, well, you're saying there's nothing wrong. It's not saying there's nothing wrong with the child. It's just saying they don't have autism specifically, but they may have a number of the similar behaviours. They still need help, but that help should have been there right at the start of the process, not waiting for the 2 years it takes us to complete the assessment. And next slide. We've talked again a bit about Digitech. I think when we started our project, we were told don't even look at Digitech, it's not relevant. Within about COVID hit about 2 months after we started, and my team were given laptops so we could do socially distanced assessment from about 2 days into COVID, having been told for years that we didn't need laptops by our trust. And obviously going forward, there's a whole load of potential developments that might add to our diagnostic process, things like artificial intelligence and so on. And next slide, please. I think rather than go through the conclusions, we've talked through, it'd be more useful if we give you probably about 10 minutes now to ask any questions. I don't know if there are any in the chat, Will, or whether otherwise we've got the slides down. If you want to put hands up in a minute, I'll just check if we've got any in the chat first.
Yeah, there is one in the chat that I've missed. I'll by Ross, who's asking about would have been helpful if professionals had flagged sensory fine motor skills. Yes, I think that's what I was talking about. Ross or Roz was talking about earlier when I was saying about interpreting what comes back from clinical teams would be much more useful in terms of knowing that this child's sensory profile means that they're highly likely to not want to pick up a pencil, and they're going to struggle with, say, creative writing in schools. And so there are nice ways around that when you actually know that that's a problem, and there are ways of sort of gradually over time getting children used to, say, picking up pencils, or not even worrying about it at all, and say using some of those video recording pens, or using dictation software, or even using like my department at Cambridge, they use like Lego to help children build up the understanding of creative writing, because they might struggle with just imagination to start with. Yeah, so having that much more that conversation of this is the issue and this is what it means in terms of a school is something that needs to be happening a lot more. Because at the moment it seems to me that schools are the ones that have like these, well, good schools have like large interventional lists of what they will do with a child. Many of them have some evidence, many of them are anecdotally based that might work. But it's kind of meaning, what does that mean? Is that right, and is that tailored for what the child's needs actually are? Does that answer your question? I've answered it. I'm not sure if I have.
Hi, did you want to come back, Ros? The other thing I've just before you do is to add I think one of the big changes in diagnostic coding, at least the DSM-5 and ICD-11 is our latest coding. The sensory behaviours are recognised as one of the things tick boxes you need to have evidence of now, where previously it wasn't properly covered.
Yeah, mine wasn't so much a question, it was more an observation, but certainly as a parent, my child was first diagnosed when he was 3. And so some of the sensory stuff and the behaviours for a 3-year-old was pretty typical with others of his peers. But it really would have been helpful for school. Certainly sort of 5 years on, they were still looking to having an OT assessment, because they couldn't understand why he was falling off chairs and not doing certain things. So it's that whole picture of not just a diagnosis, but what does it mean with that particular individual, and how can we support them?
Yeah, I agree. I mean, I think many schools, if I'm remembering my time when it felt like there was lots of diagnosis and discharge, there are some good tools that you may well know of from the Autism Education Trust that literally enable people within schools or working with schools to very quickly audit what they think practice is that's there. And so you'd be able to say, can they do this? Do they have a voice in this process? What's their profile in terms of learning? And many schools just gone ahead and just done it themselves because it's just easier. But there are lots of tools that are out there by the Autism Education Trust that enable schools to be able to just take the bull by the horns and get on with it.
Yeah, I'm a real advocate for the Autism in Schools project. So my son, it took a change of provision before anyone actually asked about a sensory diet. Never heard that term before.
Right. Often the case, isn't it?
I have a very interesting question from Helen Tanyan. Do you want to ask it out loud, and then we can make it a conversation?
Okay.
Hi.
Oh God,
It's the kind of elephant in the room, isn't it?
One of the, yes. So are the priority recommendations from the findings likely to influence investment plans within ICS and local areas?
Yeah.
I'm optimistic at one level. we've worked with NHS England, and I think the sort of debate over neurodevelopmental pathways is still a bit up in the air. I think because we made the mistake, well, not the mistake, because I think it had to be acknowledged that if you rush into it, you risk crashing services, because if you just ask my team, for example, to take on ADHD or learning disability alongside autism without giving us additional resource, we are already overstretched doing the autism work. And I think the ICSs to me are absolutely key, because if you can bring together, say the CAMs and CDCs to work on this together and come up with a shared solution, and not, as we said, I probably am more guilty of it as a health professional. We're thinking diagnosis as a health process. Actually, looking after the child and getting the best journey for that child, it's integration across health, social care, and probably more, and in children, education, even though education aren't technically part of the ICSs, because the government in its wisdom, I probably shouldn't say that here, we're looking primarily at what was needed for care of the elderly, where education isn't part of the process. And obviously, if you want to get people out of hospitals into home or sort of care settings to free up beds, that's social care and health for the two relevant agencies. But for children, education are so central, so we need them to be part of that process. Will ICSs bite? I think it's going to be local level, how you're able to influence that. In our patch in Sussex, our ICS, we had a meeting with one of the leads who's looking at the autism, and they're actually calling it neurodevelopmental pathway. And it struck me that what they were proposing, even before we'd had more formal meetings, pretty well, I said, well, you might as well have given my talk that I was going to give them the next day presenting these findings. So our ICS, I think, gets it. I think the real challenge, we said to them at the end of the last meeting we had, we've come up with a really good idea, an approach here, but is there any money? And that remained the challenge. So, and I guess you look at from a healthcare perspective, yes, the government's talking about 6 billion over the next 2 years extra funding, but they immediately, the last 2 days or so, said, well, the first 2 billion, if that's going into A&E waiting times, and we're going to have more ambulances and more hospital beds. I don't know if they've actually thought you need staff to drive the ambulances and to look after the patients in the extra beds, but it's, yeah, there's so many other competing priorities, and yes, autism is important, but it's competing with, and neurodevelopmental conditions are important and have a big impact on the lives of those families and children where it's an issue. But where does that fit in terms of national priorities when we've also got huge waiting times, we've got cancer problems, etc., etc. I'm hopeful that over time things will improve, and at least we've given this is a framework people can work to. And I think it's important with events like this. We're keen to spread the word, and we will be publishing our findings as soon as we can finish writing the papers, and hopefully get nice friendly journals to publish. But yeah, I think you need to be taking it on at local level, having champions who have a voice with the ICS, and also, I guess, being able to talk between provider trusts and getting education on board and so on. Does that help, Helen? Or I've probably waffled my way into a sort of half answer.
No, it's kind of really reassuring, because it's a journey, isn't it? And it's so complex, and I think there's so many partners involved, and we do want it to do it well where we've got gaps. So it is about process mapping, as you say. It's kind of, I think your recommendations will be a good kind of vision as to this is where we need to get to, this is where we are, so where do we need to even innovate, where we've got the gaps, and kind of bringing parents, young people that have walked that journey on board, you know, a kind of making those decisions alongside strategic, you know, those that hold the pots and make those strategic decisions. It's kind of, it needs to be co-produced. That's the whole, yeah. But it's going to be a long journey before we actually get there, I think, in the current climate.
in the current group, I know last time we had a few commissioners and people working within ICSs. Is there anybody within an ICS setting who's willing to comment? Natasha?
Hi, I'm a DCO in an ICB. Yes, I mean, I think we are trying to do exactly that, where we have CDS actually doing 0 to 18 ASD diagnoses in some of our boroughs, and CAMS doing some others. And there's definitely been concerns around having, exactly as you say, the right skill set to manage the mental health needs as well as the diagnostic processes. And it's not always that easy to bring all the stakeholders together in agreement, because they've all got their own agendas. But that is certainly what we're trying to do. It would be great if we could. I mean, I think some of your recommendations are really fantastic. So, and it's really helpful to see that you've shown that, you know, what the more efficient pathway is, because I think at the end of the day, money's tight. So if we can do that, then agree. And I also really like Will's bringing in education. I have previously worked with a head teacher who said that, you know, he used to do of a special school. He used to do all the work in, you know, kind of the assess, plan, do, review process. And then when they sent them off for the autism diagnosis, the team there would start right from scratch and get all the information themselves, rather than integrating the valuable information the school had already gathered. So I think that's really back that.
Just going through, and Ruth, you've got your hand up, so do you want to ask now? Try it. We also had a question about Digitech. But yeah, Ruth, go ahead.
Yeah, sorry, I work in Bradford District and Craven ICB. Well, West Yorkshire ICB, Bradford District and Craven Place. Very complicated. And we've done lots of work around neurodiversity assessment pathway, just because we've got a massive waiting list, and we've actually managed to reduce our waiting list throughout the pandemic, but it's just with a great deal of effort. But we've still got massive long waits. We're still sort of probably got longer waits than everybody else in the country. And it is a recognition really of how well we have 3 providers. So we've got 2 sort of paediatric acute trusts doing the front end, doing the younger children, and then our CAMS service who do all the 7+ children, but they work together. And our last business case was a joint business case and a shared allocation of funding, and so we very much are working together. There's lots of challenge and workforce. I recognise the workforce challenge greatly, and we then opened up our pathways to allow schools, particularly Senkos, to refer, and so all the good work we'd done disappeared overnight as the Senkos, and mainly they're appropriate referrals as well. So that's interesting. We're addressing unmet need, I think, and there will still be unmet need. And we know that our referrals for girls are still lower than the referrals for boys and all those kind of things. I just wanted to throw in really that we have a research programme going on across Bradford District of Craven that some people will be aware of, but this is very much around making our communities sort of neurodiversity friendly, but working in schools, so that early identification of children and young people through doing the neurodiversity profiles in school settings, starting in primary schools. And
that they're born in Bradford.
Yeah, it's out of board in Bradford, and supporting sort of working with schools for them to understand what they can put in place. So all the things that we get told schools do, but we know in reality some schools are really, really good, and some schools won't touch a child unless they've got a diagnosis. This is about going into those schools and giving that training and education and extra support, and developing resources online that they can contact there. So it will take some time, but actually we were one of the last send inspection areas in the last send inspection regime, and everything that came out, as well as having to reduce our waiting times, it was about the support offer that's out there during diagnosis and following diagnosis. And we are very clear that health cannot fix this. It has to be a much bigger sort of community-based approach, both from schools but also the wider community as well. So we're looking at that.
I know DFE are proposing that sort of the Bradford model.
Yeah.
And there's a research group, I think based in Canterbury, so in our sort of region, who are also trying out in a couple of places. So the one I know they're doing is in Hastings, so quite close to us. The paper I saw where they'd done the screening in schools at the end of their reception based on the EYFS.
Yes.
I thought that was fascinating that they had, I guess, before that, a prevalence, if you've worked it out, was about 1.5 per 100. Once they'd done the screening, it doubled. So they were looking more around about 3 per 100. Yeah. And most of the children that were picked up were ones from ethnic minority backgrounds with poor English, who otherwise probably might well not have come through the system.
Yeah. So they've taken that research and built on it, and they're now sort of working actually directly with a number of schools in the community with a slightly adapted tool, but very much along that line. And so identify them those young people early and get that support in as early as possible. And then with the thought that some families, and we are hearing it, some families then don't go on for diagnosis because they feel they get all the support they need, but it will remain in our district at the moment. It remains a choice for families. They can continue and have that diagnosis if that's what they choose.
I'm conscious we've probably overgone. I'm happy to answer a couple more questions, so I don't think there's anything else after this. I know on Digitech, it's been interesting. Obviously, COVID has changed the whole picture around using Digitech in assessment. Our experience, or the sort of feedback, was quite mixed. Some people really liked, both parents and clinicians found it a positive. I've had parents locally who've sort of talked about, actually, it was really quite nice receiving a diagnosis when we were sitting at home. We were in our safe place. But then other parents who, and again, children have said, how can you know I'm autistic based on 15 minutes watching me on a computer when you couldn't see half my body, and things like that. So they're very mixed views. I think going forward, there's definitely a role for using things like history, online history, potentially some observation. And again, there was although a lot of teams in the UK used BOSA, we've linked up with the team in Vanderbilt, which is in Nashville, who developed the ASD Telepeds, which was much more evidence-based. But their context was that they cover the whole of Tennessee and have patients who live 90 miles or more away, who are their most deprived population. There's no way they can afford as a team to go out on a 180-mile round trip for those children on a regular basis. But equally well, there's no way that those families are going to come into them. So they developed the Telepeds pre-COVID as a way of overcoming geographical isolation rather than social isolation that COVID imposed on us. But I think, going forward, artificial intelligence, looking at different apps, and we've developed our own app looking at tests that you can use to test things like theory of mind in the context of a pirate adventure game, which we've got quite good evidence. So from our sort of validation work, it's quite good in primary school age children. I think, are there any other key questions you spotted in the chat? Well, I like the comments about why are we working separately with CAMs and CDCs. And I agree, it's very challenging, though, in reality, that you have to overcome years of us working separately and all the mistrust and everything. And in our area, our CAM service is based 15 miles away. If you're co-located, at least you have those corridor conversations and things that make it much easier to get going. And it's about our different priorities. So a lot of managers in our CAM service are very focused on adolescent mental health, and they're struggling to deliver that. Equally well for us, we have a role around paediatric or neurodisability and so on, and we have to balance. We're not just an autism service. We still have a range of other children we need to see. But it's those sorts of things that going forward we need to overcome, because yeah, in an ideal world, the sort of integrated sharing our skills is the way we're most likely to get to a really good outcome.
I think I handled most of the things in the chat, Ian. So I think hopefully most people have had a chance to read that. So I think we might be coming to a close. Thank
you for listening, and thank you also for all the contributions you've made. It's been really interesting. And yeah, if you've got questions, by all means get in touch. Again, go